Good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled Each Hour Counts, Physician and Pharmacist Perspectives on the Value of Rapid Blood Culture Testing. My name is Andrew Jordan, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speakers. This webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen. And if you require any assistance, please contact me at any time by sending a message using that chat panel. And at this time, all participants are in a listen-only mode. And please note that this event will be recorded and made available to you for future download. And today, live audience members can apply to receive a professional acknowledgement for continuing education or PACE credit issued by the American Society for Clinical Laboratory Science through our exit survey at the end of today's session. And at this point, I would like to thank Nanosphere, who helped develop the content for this presentation. Nanosphere is dedicated to enhancing medicine by providing targeted molecular diagnostic tests that can lead to earlier disease detection, optimal patient treatment, and improved healthcare economics. Their platform, the Verigene system, enables clinicians to rapidly identify bacteria and viruses responsible for some of the most complex, costly, and deadly infectious diseases. Currently, the Verigene test menu targets infections of the bloodstream, respiratory tract, and gastrointestinal tract. All right, well now I'd like to introduce our first speaker for today's event. Dr. Maren Koloff is currently a professor of medicine at Washington University School of Medicine and the director of critical care research and respiratory care services at Barnes-Jewish Hospital. He's received numerous teaching awards and is a recognized expert in the performance of clinical outcomes research in the ICU setting. His clinical research focus has been the understanding and prevention of nosocomial infections and the improved care of mechanically ventilated patients. Dr. Koloff has published extensively in the areas of ventilator-associated pneumonia, prevention and treatment, and the importance of antibiotic resistance in the ICU setting. And our second speaker for today, Dr. Brad Crane, is a clinical pharmacy specialist in infectious diseases at Blount Memorial Hospital in Maryville, Tennessee. He completed a postgraduate training with a pharmacy practice residency and critical care specialty residency at the University of Tennessee Medical Center in Knoxville, Tennessee. Dr. Crane was a critical care pharmacist for 10 years before he justified and transitioned into his current role as the infectious diseases pharmacist and director of the Antimicrobial Stewardship Program. Dr. Crane is a board-certified pharmacotherapy specialist and has presented at several professional meetings on antimicrobial stewardship and rapid diagnostic testing topics. And it's with my pleasure to hand the microphone now over to our first speaker for today, Dr. Maren Koloff. Dr. Koloff, you can begin your presentation when ready.
Hello. My name is Maren Koloff. I'm a professor of medicine at Washington University School of Medicine in St. Louis, Missouri. I'm also an intensivist practicing at Barnes-Jewish Hospital. And today I'll be discussing the need for rapid decision-making in critically ill patients from the infection perspective, and really giving you some of my perspectives as a clinician and researcher in this area. When we deal with critically ill patients, timing is everything, especially when it comes to providing life-saving therapies. And certainly when it comes to the management of infections, this is an important issue as well. We know, as I'll show you, that when we provide antibiotic therapy that's directed against the pathogen causing infection, patients are more likely to do well than patients who receive delayed appropriate antibiotic therapy. Let me just present a case to you that will illustrate some of these points. This was a 32-year-old man. He was a Hispanic gentleman who had type 1 diabetes. He worked as a long-haul truck driver, and he had fevers and chills for approximately 1 week. He then developed a cough that was productive of thick green mucus sputum, and he also noted that he was becoming more short of breath and having some episodes of dizziness. It was important to note that in his history, 8 weeks prior to this presentation, he was hospitalized for the administration of IV antibiotics for treatment of a severe cellulitis on his left leg. When this gentleman presented to the emergency room, his temperature was 102.8 degrees Fahrenheit. His blood pressure was diminished at 92/54. He was tachycardic with a heart rate of 112, and he was also tachypnic with a respiratory rate in the 40s. Oximetry was placed in the emergency room, and it was noted that he required supplemental oxygen, but despite 10 liters of oxygen being administered by a nasal cannula, his oxygen saturations were only in the high 80s. He was alert, but only to person. He had obvious labored breathing. He also had a prominent cough and again was bringing up purulent secretions. And on physical examination, coarse rales could be heard at the right base. The laboratory data and the chest X-ray were obtained in the emergency department. And from the laboratory perspective, one can see that this man had an elevated white blood count at greater than 29,000, and these were primarily neutrophils. His platelet count was normal. His band count was about 50%, which was elevated. It also appeared that he had evidence of tissue hypoperfusion based on a bicarbonate that was diminished, an elevated anion gap, and he also had an elevated creatinine and BUN, also indicating that he had diminished perfusion to his kidneys. The chest X-ray shows that he had an infiltrate involving the right lower lobe, which appeared to be silhouetting part of the diaphragm and the right heart border. All in all, the clinical presentation, along with the laboratory data and the findings on the chest X-ray, suggest that this man had a pneumonia, and really based on the available scoring criteria, a very severe pneumonia with a high predicted rate of mortality, meaning greater than 10%. The decision for the clinician facing this man in the emergency room is what to treat him with. Obviously, there are many different antibiotics that can be targeted for various pathogens. Possible causes of infection in this man could be MRSA. Would one use vancomycin? MSSA. Would one use linezolid to cover for both MSSA and MRSA, or would one use a combination of a beta-lactam and vancomycin? For strep pneumoniae, there are obviously a number of different agents. Ceftaroline would be one that could also cover Staph aureus. One could consider treating more common community pathogens, such as strep pneumoniae, Haemophilus influenzae, Mycoplasma pneumoniae, possibly atypical pathogens like Legionella, which could present with this type of a severe pneumonia. Viral pneumonia, although the presentation is a little atypical, could still be a possibility. And then, very importantly, given the fact that this man was previously hospitalized, during which time he received intravenous antibiotics that would increase his risk for being colonized and potentially infected with more hospital-acquired or nosocomial pathogens, something we would refer to as a healthcare-associated infection, or in this case, a healthcare-associated pneumonia. So pathogens like Klebsiella, Pseudomonas, MRSA would have to be considered in a differential diagnosis. So one can see that we're dealing with a broad spectrum of potential pathogens, which would make us have to consider a relatively broad empiric antibiotic regimen if we were to cover most or all of these pathogens. If we look at what's happened over the last 20 to 30 years, it's clear that bacteria have become progressively more resistant to antibiotics. A good case are the gram-negative bacteria, if we focus at beta-lactamases that are being produced or expressed in them over the last 30 to 40 years. And one can see that regardless of the class of beta-lactamase, there's been almost an exponential increase over time. And there continue to be new beta-lactamases identified almost on a daily or weekly basis. At the same time that we've seen this uptick in resistance, not only in the gram-negative bacteria, but in gram-positive bacteria, as well as in yeast and fungi, the number of new antimicrobials that have come to market has diminished. And one can see that as recently as 2010, the number of new antibiotics that have been approved has dipped to an all-time low of 2. There's hope that this will reverse, and there have been some initiatives in place for that. But again, it places this in stark contrast to the escalation in resistant pathogens that we're dealing with in the ICU as well as outside of the ICU setting. This problem of increasing antimicrobial resistance has become so paramount that there are some estimates, such as this one from the Wellcome Trust in the United Kingdom, suggesting that by 2050, the numbers of attributable deaths to antimicrobial resistance will be greater than 10 million. Now, most of these will occur in less developed parts of the world, such as Africa and Asia. But even in the United States, it's estimated that well over 300,000 deaths will be attributed to antimicrobial resistance by 2050. Recognizing this problem, the fact that we have increasing antimicrobial resistance and potentially limited numbers of antibiotics, especially new antibiotics, this really places a problem for the clinician in terms of trying to treat the pathogen in a timely manner. On the one hand, we know that if we give the right or the appropriate antibiotic to the patient as early as possible, their likelihood for a cure and survival is increased. On the other hand, we also know that the more we use antibiotics, particularly broader spectrum agents, for prolonged periods of time, one is more likely to see escalation of resistance. So somehow clinicians have to be able to balance this, trying to treat the individual patient while at the same time trying to minimize the emergence of resistance. Being an ICU practitioner, I'm faced with this problem on a daily basis where I'm dealing with patients who come in who have septic shock and other serious infections. And for that individual patient, the key issue is getting the right drug to them as quickly as possible. We actually showed almost 15 years ago that when we prospectively looked at 2,000 patients in our medical and surgical intensive care units, that roughly 1/3 of them had a microbiologically confirmed infection. And of those individuals, about 1/4 received treatment with an antimicrobial agent that was not appropriate, meaning it was not active against the offending pathogen. What's important to recognize is that those patients had a greater than 2-fold higher risk of all-cause and infection-related mortality. So this demonstrates the importance of getting that initial appropriate therapy to the patient in a timely manner. Others more recently have confirmed these findings by demonstrating that for each hour that there's a delay in administering antibiotics to patients with serious infections, specifically appropriate antibiotic therapy, the risk of mortality increases. So you can think of this as the clock ticking. For each minute, for each hour that goes by that a patient does not receive antimicrobial therapy that's active against the offending pathogen, their risk for a negative outcome increases. We have shown this more recently in other patient cohorts, such as this one from our hospital, where we looked at patients who had gram-negative bacteremia with sepsis. And again, we found that patients who did not receive initial appropriate antibiotic therapy had the highest odds ratio for mortality, with an odds ratio of almost 4. So again, it demonstrates the critical importance of identifying pathogens and, more importantly, getting the right therapy to the seriously infected patient as quickly as possible. Another study focusing on a specific pathogen, in this case Klebsiella pneumoniae Bacteremia, nicely showed that as you go from less resistant to more resistant organisms, so the non-ESBL, non-KPC to the ESBL to the KPC, the likelihood that the initial therapy would be adequate or appropriate decreases. And in fact, as the adequacy of the therapy decreases, there's a decrease in survival. So this is the vicious circle that we're dealing with as clinicians. On the one hand, as resistance increases, it becomes more difficult to appropriately treat patients with empiric antibiotic regimens. And on the other hand, we know that if we don't prescribe an appropriate antibiotic regimen, the patient's risk of mortality increases. So somehow this balance, this problem that we're dealing with on a day-to-day basis has to be resolved. And the practical approach is something that we call de-escalation, where clinicians look at the patient, obtain the history, and try to gauge the patient's risk for infection with more resistant pathogens, and then prescribe broad spectrum versus more narrow spectrum antibiotic regimens based on that evaluation. Just another study to demonstrate this fact, Acinetobacter Bacteremia, again from our institution, something that we really did not see 10 to 15 years ago, but now is becoming a more common event. We also see that with this pathogen, the most important driver for mortality is patients who do not receive initial appropriate antibiotic treatment. And one can see that the mortality for those patients who receive initial therapy that is not active against the organism is 50%. Again, highlighting the importance of targeting therapy to the pathogen. But it almost really doesn't matter what pathogen you're dealing with, as shown by Cristina Vasquez-Guillemette, again from our institution, demonstrating that regardless of the pathogen, when you look at the number needed to treat in order to save one additional life with appropriate antibiotic therapy, the numbers are very similar, whether you're dealing with MRSA, Klebsiella, multi-drug resistant gram-negative bacteria, or other pathogens, somewhere in the range of 5 to 7, meaning that it only takes 5 to 7 patients being treated with an appropriate antibiotic regimen in order to salvage one life. Again, highlighting the importance of this issue. It's not just the patient's outcome, it's also the economics of getting the right therapy on board as quickly as possible. David Zhang from our institution looked at this in patients who were bacteremic and septic, demonstrating that as one delays the administration of appropriate antibiotic therapy during the first 24 hours after onset of infection, the hospital length of stay increases. So that for a 24-hour delay, hospital length of stay increases by almost 2 days. This really can provide an economic justification for strategies aimed at more timely identification of pathogens in order to ensure that the initial antibiotic treatment is appropriate and adequate for the organism. Just to highlight this problem from a global perspective, we know that resistance is not limited to one country. as demonstrated by the presence of KPC being essentially endemic now in many continents, including North America, South America, Europe, and Asia. Even more concerning is the fact that we have fewer antibiotics to deal with these pathogens. Nevertheless, we know that there are strategies that we could put into place that help to balance the need to treat the patient appropriately and the societal need to try to limit unnecessary antibiotic administration. One of those studies, done now almost 16 years ago, was by the group in Paris, Jean Fagan and colleagues, where they basically looked at patients in the ICU setting who had suspected ventilator-associated pneumonia. And the patients were randomized to one of two arms. In one arm, they had clinical management of their suspected VAP without an invasive bronchoscopic approach that included quantitative cultures and gram stain of the BAL specimen. In the other arm, they did have the invasive approach, where patients had a bronchovelar lavage performed and then had quantitative cultures, gram stain performed of those specimens, and those specimens dictated subsequent antibiotic therapy as demonstrated by the protocols that they had developed. What they found that was interesting was that there was a survival difference at day 14, which was statistically significant, which became unsignificant by day 30, but nevertheless, overall survival was greatest in the group of patients who were managed using the invasive approach, where the pathogens were identified and therapy was directed to those pathogens in a more specific manner. They also showed that not only was survival improved, but that patients who were managed using this invasive strategy had more antibiotic-free days. So now we have a situation where patients are receiving fewer antibiotics, yet their overall survival is at least equal, if not better, than patients who are being managed in a more traditional approach where they may receive longer courses of empiric antibiotic therapy because the microbiologic data is not as specific as one might want. Our own approach, which I alluded to earlier, is one of de-escalation, where again, the clinician tries to determine from the patient's history and the clinical evaluation of that individual what their likelihood is for infection with more resistant organisms, in which case one would start with broader empiric antibiotics, but then based on the microbiology, narrow the spectrum of those agents if possible, as well as the number of antibiotics if possible. There are many studies now that have demonstrated the overall safety of this type of de-escalation approach. However, in many hospitals, it is not rigorously followed because of concerns over clinicians' ability to accurately identify pathogens, with the concern being that one might miss a pathogen using routine microbiologic results. Nevertheless, in our institution, Ahmad Ibrahim showed that when one used this type of an approach in an ICU setting for the management of ventilator-associated pneumonia, where one would initially treat with a combination regimen which at the time would cover more than 90% of the VAP pathogens, and then based on the microbiology obtained using lower respiratory tract cultures with quantitations of gram stain, where one had to modify the therapy within 48 hours based on that microbiology, and no patient could be treated for more than 7 days unless they had specific findings suggesting the need for prolonged therapy, such as lack of resolution of symptoms or bacteremia. One finds that using this type of an approach in this before-after study conducted in the medical ICUs of Barnes Jewish Hospital, the appropriateness of the initial antibiotic therapy was greater, approximately 90% versus 50% based on the prior historical control year. There's nothing surprising about this. The clinicians understood what the pathogens were that were causing VAP and empirically started with a broad spectrum regimen in order to cover the majority of those. The problem is continuing such a broad spectrum regimen could provide more resistance. However, what these clinicians showed was that using de-escalation, using the microbiology, they were able to narrow not only the spectrum of the antibiotic agents, but also the duration of therapy from an average of about 15 days down to about 8 days. And in fact, overall emergence of resistance was less. So another example where one can use the microbiology to dictate what the subsequent therapy should be in terms of antibiotic duration and spectrum of antibiotic therapy. Another more recent question that's come up because of the availability of new technologies is whether or not we should be screening patients in our ICUs, particularly those with respiratory failure and pneumonia, for the presence of respiratory viruses. And increasingly, I think now the answer is becoming yes. These are just a couple of examples. This is a 38-year-old man who had end-stage respiratory or renal failure on hemodialysis, who also had respiratory distress with diffuse infiltrates requiring intubation and mechanical ventilation. Broad-spectrum antibiotics were initiated in the emergency department and continued when the man arrived in the intensive care unit setting. A BAL was performed shortly after arriving in the ICU, and interestingly, there were more than 32% lymphocytes and 48% neutrophils. H1N1 was identified in the BAL fluid, and all the bacterial cultures were negative, allowing the broad-spectrum antibiotics to be discontinued. So again, in this case, a nice example where understanding the pathogen allows for a more appropriate prescription of antimicrobial therapy. Just another case of a man who's a farmer in southern Illinois who presented with diffuse histoplasmosis, again complicated by respiratory failure, a prolonged course in the ICU, had multiple bronchovelar lavages that were performed, primarily because of either worsening of the infiltrates or worsening of gas exchange parameters. And what one can see here is that the percent of neutrophils, lymphocytes, eosinophils, and macrophage varied. And in fact, on the third row, when the person underwent bronchovelar lavage, one can see that the number of neutrophils, percent neutrophils, was high at 38%. Lymphocytes were lower. But with the first BAL, the number of lymphocytes was higher. And again, that was when the presence of rhinovirus was also detected. So again, one sees here that one had a situation where this man with diffuse histoplasmosis had a superinfection, if you will, with rhinovirus, but no bacterial infection. Again, complicated scenario, but allowing for a more directed approach to the antibiotic therapy. There have been some other studies done more recently trying to look at the use of rapid diagnostic methods as a means of directing our therapy both in and out of the ICU setting. Bork and colleagues at the University of Maryland used rapid testing with Verigene on blood cultures in patients with gram-negative bacteremia as part of their antimicrobial stewardship program, and nicely showed that both effective and optimal antimicrobial therapy could be prescribed in a more timely manner using that rapid diagnostic approach. Another study by Box and colleagues from the Scripps Health Center, also done as a before-after study, looked at the use of a rapid diagnostic to determine whether or not antimicrobial therapy could be directed in a more timely manner. And again, similar to the prior study, these investigators found that the targeting of antibiotic therapy was more directed in the intervention group, resulting in less time to the administration of appropriate therapy in those individuals. So I'm going to conclude by saying a few things here. First of all, I think it's very important that everyone understand their local epidemiology. Obviously, in an institution like mine, it's very different from that in a community hospital down the road here. And by understanding that local epidemiology, clinicians must try to optimize the initial treatment of infected patients, especially patients with serious infections in and out of the ICU setting. That means trying to select the right drug for that infection, which often means a combination of therapies. They have to be dosed appropriately. The duration of therapy has to be appropriate. But now we also see that with the use of more rapid diagnostic methods, we have the potential of even improving upon our clinical assessment in terms of directing the initial therapy and potentially even augmenting our ability to de-escalate therapy in order to minimize the development of future antibiotic resistance. Thank you very much for your attention.
Great. Well, fantastic. Thank you very much for that, Dr. Koloff. And now I'd like to hand the presentation over to our next speaker, Dr. Brad Crane.
Thank you, Andrew, and thank you, Dr. Koloff. I appreciate it. I'm very excited today to talk to you and give you my perspective as a pharmacist, and also from the perspective with the impact it can have on antibiotic stewardship with this rapid diagnostic testing, and particularly our experiences here in our hospital, paying particular attention to positive blood cultures and being gram-positive blood cultures. What I'm going to talk about today is to review the correlation between rapid diagnostic testing, or RDT, with antibiotic stewardship programs, to list some potential clinical and financial outcomes or metrics that are associated with this technology. I'm going to briefly review the responsibilities that in our institution that the microbiology and pharmacy department has, and hopefully to determine the feasibility of implementing this technology, not just in large academic medical centers, but in an institution like ours. A little bit about our hospital. I think it's important to review so you can see if your facility might be relevant to ours. Plum Memorial is a 304-bed with an average census of 220. We are a non-teaching community hospital located in Maryville, Tennessee, which is just outside of Knoxville. We do have a formal antibiotic stewardship program that was implemented about 4 years ago, and it's primarily pharmacist-driven. And a little bit about our micro department. It is open 7 days a week, but very similar to other community hospitals, it's limited. It's just open from 6 a.m. till 2 p.m. The staff, there's usually about 4 people on staff per day. And since we're talking about gram-positive bacteremia, it's probably good to know we average about 2 positive blood cultures per day that are gram-positive. A little bit about our stewardship team. In correlation with the guidelines, it's primarily myself and an ID physician, which we actually do pay them for the time that they spend with us. And then initially, as needed, it was the clinical microbiologist and infection preventionist as well. But now that we've been underway for a while, I can actually say that on a daily basis, I'm talking to my microbiology department, so much so that they're kind of realizing, yep, it's Brad. I call them multiple times a day. And our ID physicians, really I contact them more on an as-needed basis, possibly for complicated patients, but less so and more so with a micro department. So for those that may be less familiar with what antibiotic stewardship is, the primary goal is to optimize the clinical outcomes associated with our antibiotic use while minimizing the unintended consequences of them. Examples could be of the unintended consequences of toxicities or side effects of those, such as kidney damage, the selection of pathogenic organisms, or the induction of C. diff by using the other antibiotics, And one thing that Dr. Koloff mentioned was the emergence of resistance. Resistance is nothing new, but it's now being higher recognized. And it's not considered a national security threat, so much so that President Obama actually issued an executive order last September of 2014, and there's now since been produced a national action plan on how to combat antibiotic resistance. If you do everything that we should be doing, a secondary goal is also to reduce healthcare costs. So some examples of what stewardship are. One of the first things to get the biggest impact of stewardship is really to have a real-time process or prospective audit. So I'm working with physicians with the same information they have. It's not just retrospective chart reviews. One of the biggest examples of stewardship is there even a need for antibiotic? Dr. Koloff mentioned about viral infections. If it's a virus, let's not give them an antibiotic. Or could it be heart failure instead of pneumonia? Or is it chronic lymphedema and not cellulitis? So let's not give them antibiotics if we really don't need to. But in the event that we do need an antibiotic, let's put them on the most appropriate antibiotic. And one of the biggest things that Dr. Koloff mentioned, and I absolutely agree with, is the de-escalation of antibiotics, especially once we get more information. And as he explained, the de-escalation is the concept of going to a more specific antibiotic, or what I like to refer to as using more of a sniper to kill the organism that has much less collateral damage compared to a big bomb antibiotic. One of the biggest things I'll do as a stewardship pharmacist is to make sure that the antibiotics that we do use have a high enough dose so that it's being effective, but not so high that it's becoming toxic. And then one of the biggest things I'll focus on is the duration, which is sometimes a tricky answer, but really working with our physicians to say, do you think it's safe to stop the antibiotics at this point? And one of the things I'll do with most of my recommendations when I work with physicians is to also educate them. Many of them don't have a whole lot of training in this area, so I think it helps when I give them a recommendation. It's not just what the recommendation is, but also to give them the why behind the recommendation as well. So what is the connection between antibiotic stewardship and rapid diagnostic technology? Well, studies have shown that when you do rapid testing of positive blood cultures, that we can see clinical and financial outcomes. The clinical outcomes can be seen by a decreased time to that optimal antibiotic regimen. And for me as a stewardship pharmacist, that's really one of the biggest things I like to do. I want to put them on that optimal antibiotic. Studies have also shown a decrease in length of stay, both in overall hospital length of stay and ICU, and also improved mortality as well that, again, Dr. Koloff mentioned. Financially, there's been shown that this technology will decrease overall hospital costs. A lot of that's because of a shorter hospital length of stay, and also decreased costs associated with just antimicrobial use. So one of the first questions is, how are we seeing these outcomes? How's the technology doing it? Well, one of the first things is to realize the normal process. So I'm sure many of you are probably aware, as soon as a blood culture turns positive, the most common response is what? Place them on empiric vancomycin. And it could mean they don't have symptoms, or they might, but no matter what it is, they're going to start with vancomycin. Well, where rapid diagnostic testing comes in, it actually decreases that time to the knowledge of key information. And how to do so is by looking at the conventional process that most of you are probably familiar with. You got to wait for the organism to actually incubate. And from the time that you start getting growth, and they do a gram stain, to the time that you can actually identify and get susceptibilities, on average, it takes anywhere from 2 to 4 days. Well, when you integrate rapid diagnostic testing, again, you still have the same process, and you're not replacing that process. But usually, with most of the technology, once you get growth of the blood culture, you're going to do possibly a gram stain, and this is when you're going to do rapid diagnostic testing. So rapid testing doesn't make anything grow faster, but when you do have growth, it gets the identification faster. And specifically at our institution, if the blood culture is a gram-positive organism, then all of a sudden we get, instead of 2 to 4 days, we get 2.5 hours. We get that result and key information, and then that's when we can take action. At our institution, we use the Verigene gram-positive blood culture test, and I want to review briefly some of the information that we get. This technology will tell us if it's just a staph species or if it's a strep species, but then also very specific species as well, such as, is it a Staph aureus? Is it Staph epi? And then there's certain strep species as well, such as strep pneumoniae, group A and group B. And then this technology also will differentiate between Enterococcus faecalis and Enterococcus faecium. This technology will also give us resistant determinants, in which, all in all, there's a total of 16 combinations, including our multi-drug resistant organisms of MRSA and VRE. Here's an example of what the report looks like when it comes off the machine. And in this example, you can see that this patient had Staph was detected. Staph aureus was also detected. And because it was a Staph aureus, it also looks for MEC-A. In this case, MEC-A was also detected. And for us, we know how to interpret that to show that they have the methicillin-resistant gene. And also what is detected is also important, but also what's also important is that things that are not detected. In this case, it tells me that this patient does not have Enterococcus. And sometimes knowing what is not there is just as important to know what actually is there. What's nice is that it has a nice summary, so I don't have to worry about accidentally missing something. So if I were to see this patient and see what they have, I would interpret this patient to have MRSA bacteremia. So getting back onto the how we're seeing this impact. Well, one of the first things is when we get this key information, it can automatically tell us, is this a pathogen that I know I'm going to need to treat, or is it probably just a contaminant that I do not need to treat with antibiotics? For example, if it's a Staph aureus or Staph lugdunensis, I know I'm going to almost always need to treat that organism. Same with strep species such as strep pneumoniae or group A, group B, or Enterococcus faecalis and faecium. I know I'm almost always going to need to treat those organisms. However, if it turns out to be a Staph epi or another coagulase negative Staph, unless they have certain risk factors that makes me more concerned, it could be a true pathogen, like it's 2 out of 2, maybe they're immunocompromised or have a pore, then in general, I probably do not need to treat those with any antibiotic at all. Additional key information I can see is when we are going to treat it, we can use that empiric treatment of vancomycin, and we can make it more targeted to the specific pathogen. For example, if it's a strep pneumoniae, I know using my local antibiogram that I can de-escalate that vancomycin down to ceftriaxone, because we have a very infrequent rate of ceftriaxone-resistant strep pneumoniae. Same with group A strep. I know I can de-escalate that vancomycin down to penicillin with or without clindamycin. When you add the resistant determinants such as MEC-A and Van-A and Van-B, I know if I have a Staph aureus and it does not contain that MEC-A, then it's methicillin-susceptible Staph aureus. And I can de-escalate that vancomycin down to either nafcillin or cefazolin. If it's Enterococcus faecalis and it does not have the Van-A and Van-B, I know it's vancomycin-susceptible Enterococcus faecalis, and I can de-escalate that vancomycin down to ampicillin with or without ceftriaxone or gentamicin that's used for synergy. And same with Enterococcus faecium. If it does have the Van-A or Van-B, I know I now have VRE, and that vancomycin isn't even going to be effective. So I now need to escalate my antibiotics up to daptomycin or possibly linezolid. These are all examples, and if I had one slide, this is probably it, that shows really how this technology will allow me to do antibiotic stewardship. These are all examples in which that empiric vancomycin is going to be able to be changed to a more narrow spectrum antibiotic, which is usually going to be better for the patient, and it decreases our hospital and patients to unnecessary vancomycin utilization. So getting back to the studies that I talked about, one of the key things to know is that most of the information out there up until the last, maybe within the last year, most of the information out there has all been performed in large academic medical centers. However, most of the hospitals out there are not in that kind of setting. It's more similar to us, where we're more of a community hospital that's non-teaching. So the question is, would we be able to see that same kind of outcome in a hospital such as ours? Well, that actually led us to do the pilot in our hospital to actually see if we turn out to have the same kind of results. So we want to see if we saw the same potential clinical and financial impact of using this technology in conjunction with our stewardship program at our specific hospital. The objective was to determine if this technology would potentially affect the hospital length of stay, with secondary outcomes looking at the ICU length of stay, time to that optimal antibiotic regimen, and hospital costs. This was an IRB-approved retrospective chart review, and we looked at a 3-month period right after we started the rapid diagnostic testing. And we compared it to a similar 3-month period 1 year earlier. We included all patients who were admitted to the hospital that had a positive blood culture for a gram-positive organism, and the rapid diagnostic group was the exact same. it was just those who actually had the test that was performed on them. And the exclusion criteria is listed there, with the most common exclusion criteria being patients that had a sample collected from the ED, but who were never admitted inside of the hospital. We reviewed 188 patient and blood cultures. There was 99 in our historical control group and 89 in our intervention arm, the rapid diagnostic group. Both sides had very similar exclusion criteria, again, ED patients being the most common. And that actually left a perfect 73 people in each arm, which made our analysis that much easier to perform. I've listed a lot of baseline characteristics that, for time's sake, I'm going to kind of breeze through. But I did want to point out that there were statistically more recommendations accepted from the pharmacy department by physicians in our RDT arm. But we also had a pretty high success rate as well in our historical control. What kind of recommendations were we making? Well, you can see here that 81% of our recommendations had some kind of recommendation to change the antibiotics. But we also had a pretty frequent rate of recommending to consult our ID specialists. This graph shows the correlation between organisms in the different arms, and there was no statistical significance between any of them that may have impacted our outcomes. And this graph also shows that the majority of our our isolates were actually coagulase negative staph. However, we did see some Staph aureus and strep as well. Further driving down into these organisms, one thing I did want to point out is that we had similar rates between those that were pathogens compared to contaminants, as we would expect patients who have true pathogens would probably be in the hospital longer. And same with specificity, we really want to know how much can we really rely on this technology. And as you can see there, 96% had a perfect match, and really only one organism may have had a clinical implication, but we're very pleased with the accuracy of this technology. The primary clinical outcome, again, looking at the overall hospital length of stay, and we showed a 1.3 day decrease on average in our intervention arm. Although it was not shown to be statistically significant, our administrators were very happy with it, and I think most of your administrators would be as well. Specifically looking at a secondary outcome of the ICU length of stay, we saw a 3.5 day reduction in our ICU length of stay, but again, did not show statistical significance, but again, heading in the right direction, and I think we'll be pleased with a 3.5 day reduction. Other secondary clinical outcomes, again, for me as a stewardship pharmacist, I really want to know how long did it take to get them on that optimal antimicrobial regimen. And our information showed that we had a 55% reduction, or 21 hours, in our intervention arm, and that was shown to be statistically significant. The status of the blood culture when the rapid test came back, this graph shows that about 2/3 of the time, the only thing I knew on the blood culture was that it was the gram stain, such as gram-positive coccidin clusters. That's all I knew. And then the other third of the time was the genus. I knew maybe it was a staph species, but that would be it. Financial outcomes. The administration loves to see the financial impact. Well, specifically focusing just on the antibiotic cost, the cumulative cost in that 3-month period between the two groups, there was an $11,000 reduction just in antibiotic savings over that 3-month period. And very similar, our hospital costs, and again, this is cost, not charges, we saw a decrease in the two groups between the control and the rapid diagnostic group of $159,000 reduction in cost. Now remember, that was only over 3 months. So if we want to extrapolate that out to a year, and if you agree this is an appropriate way to determine this calculation, that would be an estimated annual savings of $636,000 per year. Of course, the technology isn't free. I'm working with Nanosphere, asking them to give it to us for free, but not surprisingly, they said no. The cost of the test is somewhere around $75 or so, so we estimated the cost during that time period to be about $6,000. Again, you extrapolate it out to a year, that's about $24,000. But you can see, really, the savings that we're seeing is way outweighs the cost of it. So the net savings in this case was over $600,000. It's a slam dunk, in my opinion. Some limitations and barriers, especially with the pilot. Do I think the technology is the only thing that impacted the length of stay? Absolutely not. But do I think it's at least a factor? Absolutely. This technology was only performed Monday through Friday, and it was only performed from 6 a.m. to 11 a.m. And the reason why we had to stop at 11 a.m. is, again, like most community hospitals, we're not open 24 hours a day in our micro lab. So we had to make sure we had to give them enough time to run the test, which is 2.5 hours. and get all the information out to people in enough time so that they could leave on time at 2 o'clock. And then there's the initial reporting of the results. We learned the hard way that we aren't just going to report the positives, but we also report the negatives. If we don't report that a MEC-A was not detected, then that's really important to know that it's not methicillin resistant. Also, understandably, there's some initial reluctance by physicians. Brand new technology, can they really trust what it says? But as you can see with our specificity, that as the program continued, they saw where the culture was almost always turning out to be exactly what it predicted to be. And one of the biggest challenges that's still ongoing is incorporating this into our current responsibilities. Our administration would not give us any additional FTEs, either in the microlab or in the pharmacy, to run this technology. Of course, there's time associated with it, and we just have to incorporate that into our daily responsibilities. And especially during this pilot project, there was additional time that was needed to be spent on the data collection, the analysis, and then the outcomes. Responsibilities for the micro department, what we're currently doing is from 6 a.m. to 11 o'clock, we're performing the rapid test. From 11 o'clock to the next 6 a.m. the next day, we're requesting that the samples be frozen so that they can be thawed and performed the next morning. The second step for microbiology is probably the most important one, is to actually call the result to a pharmacist. And at some facilities, it could be a physician. Here we've decided to have it be primarily myself. And the biggest reason for that is studies have shown if we're not calling the information to someone who knows what to do with the information, you're losing the benefit of that information. So here they call it to myself, and then I'll assess and determine if there's any interventions that need to be made. And when I'm not available, they'll call it to the clinical pharmacist that's assigned to that patient for that floor. And we currently have about 14 clinical pharmacists that have been trained on this technology. And then the final responsibility for microbiology is to actually report that information into the computer system. So what are the pharmacy responsibilities? Well, really the main thing is basically assess the patient to see, are they being treated with the optimal antibiotic therapy? First question, do we even need to treat this organism or not? If we do need to treat it and they're on antibiotics, do we need to start them on antibiotics? They're on antibiotics, but maybe not the optimal antibiotics. Do we need to change the regimen? Or this is something we don't even need to treat. Let's stop the antibiotics that they might be on. Occasionally, we're making recommendations for additional tests, such as repeating blood cultures or maybe a procalcitonin. And believe it or not, we're actually recommending checking things like an echocardiogram or a CT MRI, depending on where we think the source of infection is. As you saw in our pilot, we're also recommending to consult our ID physician specialist. And then occasionally, we may have recommendations where we think the source of infection is. Maybe we need to remove port. Really trying to work with the clinicians to identify whatever's going on with the patient. One of the biggest questions I get is, well, how can all the other pharmacists really have the same impact? Well, what we've done, we've trained these people, and I've actually kind of come up with a little bit of a cheat sheet, if you will, because people always want to know, well, what would Brad do with this? So this is my little cheat sheet algorithm of how to interpret everything and basically what I recommend. So in this example, this shows a description of what the organism, what the genus and species is, if there's any resistant determinants that were detected, a little bit of information about what that organism actually is, and what would Brad recommend? What would be the recommended optimal therapy for that patient? So for this example, this patient, if Enterococcus faecalis was detected, and the Van A or Van B was detected, or it's positive, then in that case, we would interpret this to be VRE. And this very specific isolate would be pretty rare because only 2% of the time would we see a vancomycin-resistant Enterococcus faecalis, since most faecalis is not vancomycin-resistant. However, if we had this and the patient was considered to be symptomatic, then I would recommend empirically placing the patient on daptomycin at 8 to 10 mg per kg IV once a day, which is off-label, but it's high dose, which is what is now recommended in the guidelines. Place the patient in isolation because, again, they have VRE. So from an infection control aspect, we want to make sure we do that. Consider rechecking blood cultures if it's been more than 48 hours, which a lot of times it's not because this technology is so fast. Strongly recommend consulting our ID specialist. And for us, it's actually required since daptomycin is actually restricted. And consider checking a procalcitonin and a baseline CK. And then the final thing is to make those recommendations to a physician, but only if needed. If the physician doesn't, if the patient's being treated optimally, we're not going to bother them. And we also give them the education at the same time. So to close up, I do want to go over a patient case that we actually did have here at our institution. This patient was a 37-year-old male who came in with a chief complaint of fever and shortness of breath for the last several days. He reported a fever at home and it was confirmed in our ER, and he had been taking Tylenol and Motrin to try to suppress that fever. He had a significant past medical history of diabetes and hypertension, and he did admit to using occasional alcohol and IV drug use. And he did have noticeable allergy of penicillin. His lab showed a leukocytosis with Bacteremia and with normal renal function. He was admitted onto our floor with an admitting diagnosis of community-acquired pneumonia, and he was placed empirically on moxifloxacin IV. The following day, one of his two blood cultures turned positive. The gram stain showed gram-positive coccidin clusters, and our microbial department performed rapid diagnostic tests. While that was being ran, our physician decided to prescribe empiric vancomycin dose per pharmacy. 2.5 hours later, the rapid diagnostic came back and it showed methicillin susceptible Staph aureus. That came to me. I assessed the patient and I made the following recommendations. 1, change that vancomycin and Avalox to cefazolin, console ID, check the CT because I was concerned the patient may not have pneumonia. It could actually be a septic PE because I was concerned this patient had endocarditis, in which I recommended checking an echocardiogram. The physician accepted all the recommendations, including going to cefazolin, and of note, this patient did not receive a single dose of vancomycin. ID was consulted. The CT actually did show multiple pulmonary emboli. An echo did show tricuspid valve endocarditis, and the patient was transferred to the unit for closer monitoring. 3 days later, the patient was transferred back to the floor, and then 3 days after that, the patient was on discharged with a total of 6 weeks of cefazolin IV. Now, the potential benefits in this case of this technology is the faster time to that optimal antibiotic. There's evidence that shows that beta-lactam, which is cefazolin, is actually more beneficial than vancomycin. The avoidance of unnecessary antibiotics. Again, this patient did not receive any doses of vancomycin. And of unique concern to him, he had a lot of risk factors for going to acute kidney injury since he had diabetes, hypertension. He admitted to taking ibuprofen before he came in, and the patient also received IV contrast for that CT study. And the patient was also discontinued on their moxifloxacin, which has been shown to prolong our QT, and it's been associated with C. diff like every other antibiotic on the planet. And then there's the increased likelihood of survival. There's evidence that shows the faster time to an ID consult is likely to do that. This patient actually had a faster time to diagnose that endocarditis and the septic PE and not pneumonia. And again, that faster time to that optimal antimicrobial therapy that Dr. Koloff talked about. So in summary, I hope I've shown that this technology is an excellent opportunity for antibiotic stewardship programs. We reviewed some key metrics such as improved clinical outcomes, such as that decreased time to optimal antibiotic therapy, the decreased length of stay, and also the potential for improved mortality. There's also improved financial outcomes that our administration also likes to see. We briefly reviewed the workflow and responsibilities of the key departments, and I hope, if nothing else, that you would agree with me that this technology, even in non-academic medical centers such as ours, that this technology is absolutely feasible. And with that, I'm going to turn it back over to Andrew and see if there's any questions out there.
Fantastic. Well, thank you very much for that, Dr. Crane, and also thank you to Dr. Koloff for his portion of the presentation. At this point, I would like to invite our audience to continue sending their questions and comments in right now using that questions window for this, which is the Q&A portion of the webinar, of course. And I've already received some questions here, so let's get started. Our first question for Dr. Crane. How did the clinicians at your institution respond to the implementation of a rapid diagnostic, and did they trust the results and make treatment decisions using them?
That's a great question, and I briefly alluded to it. Initially, we actually did have some reluctance. I tried educating the physicians ahead of time. They knew they had the support of our ID physicians, which always helps as well, especially when a pharmacist is making a recommendation like this. And really the biggest thing that sold it was they would see what the rapid test would show, and then again, that 2 to 4 days later, they'd see, sure enough, it turned out to be exactly what it was. And so as they kept seeing that more and more for themselves, it took less convincing for myself, and they saw for themselves.
All right, excellent. Thank you for that. I think there might not be too much time to answer this question, but we'll go for this one. Are Are the positive blood cultures pulled from the instrument and at least gram stained by non-micro laboratories when the micro department is closed? Or are the positives only worked on by the micro staff?
That's also a great question. And at our institution currently, right now, the only people that actually perform the test on the actual Verigene system is just our microbiology staff. In the evenings, if a blood culture does turn positive, we do have people assigned to actually do the gram stain, and that's when we ask them to actually freeze it. However, I have heard of other places that are considering having people actually do it even if they're not within the micro department. It's a relatively simple technology, but again, I'm going to defer to every micro department and their comfort with the technology to see if that's an option for them. But if they are willing to do it, then that would get the information back that much faster.
Right. Okay, well, thank you very much for that, Dr. Crane. Also, thank you to Dr. Koloff. We have reached the end of the question and answer portion of this webinar. If you do have any further questions, however, you can direct them to the email address showing on your screen right now. That's webinar@nanosphere.us. Thank you, everyone, for participating in today's conference. You'll be receiving a follow-up email from X-Talks with access to the recorded archive for this event. And a survey window will be popping up on your screen. Your participation is appreciated as it'll help us improve our further webinars. Now please join us in thanking our speakers for today, Dr. Maren Koloff and Dr. Brad Crane. We hope that you found this conference informative. Have a great day, everyone.